Now, let's discuss the physiological effect of neuraxial anesthesia. What would be the effect or what would be the change in the physiology of the patient with neuraxial anesthesia? Well, it depends upon few very important things. What happens in neuraxial anesthesia? We block the sympathetic, motor and the sensory nerves. So sympathetic nerve, the spinal nerve which carries the sympathetic fibers, the motor fibers and the sensory fibers are getting blocked. Then some compensatory reflexes act, and there is unopposed action of the parasympathetic nervous system, right? Because of that, we are getting these physiological response. So these physiological response are because of blockade of sympathetic, motor and sensory nerve. Then because of the compensatory reflexes, and because of unopposed parasympathetic tone, parasympathetic tone, right? See, the sympathetic fibers of autonomic nervous system, the preganglionic sympathetic fibers, they originate from intermedial nucleus from T1 to L3 and travel along with the intermedial nucleus of the spinal cord and travel along with P1 to L3 spinal nerve, right? So they travel with P1 to L3 spinal nerve. So when these are getting blocked, when we are performing the neuraxial anesthesia in which we block the spinal nerve, so we are getting the sympathetic block. Parasympathetic nervous system, they are craniosacral. The preganglionic parasympathetic fibers originate from craniosacral, mostly from vagus, the cranial fibers, and sacral, which innervates mostly the the perineal organs and your lower intestinal segments and your bladder, etc. The parasympathetic fibers for these organs only travel with the sacral spinal nerve. Rest, the cranial part, which innervates most of the part of the body, most of the organ system, travel with vagus, which is not blocked when we are giving neuraxial blockade. So we have unopposed parasympathetic tone. If you see the sympathetic nervous system, how do they originate? The sympathetic and the parasympathetic nervous system, that is the autonomic nervous system. The sympathetic nervous system, the root value is from T1 to your L2, 3, okay? And the parasympathetic from your cranial nerves, right? And the sacral innervates only rectum, bladder and the reproductive organs, right? The rest of the parasympathetic is through the cranial, mostly through the vagus, okay, which is not blocked. These are not blocked when we are giving spinal anesthesia, and these are blocked when we are giving the neuraxial anesthesia, spinal or epidural. So all the complication is because of this sympathectomy, sympathetic nervous system blocked, and unopposed parasympathetic nervous system, and due to some compensatory reflexes we get all the clinical features. So we will discuss everything. So what is the physiological effect of neuraxial anesthesia on cardiovascular system? Now cardiovascular effect, two things we have to remember: hypotension and bradycardia. Most commonly hypotension and bradycardia. So hypotension and bradycardia is two important things which is happening with neuraxial anesthesia. Now let's first talk about hypotension, which is the commonest complication we see with neuraxial anesthesia. Hypotension. Now hypotension, there is a 47% incidence with the neuraxial. 47% incidence of hypotension with neuraxial, right? So with neuraxial, there is a 47% incidence of hypotension. Why this is happening? This is happening due to two important reasons. One, because of the loss of the sympathetic tone, there is a peripheral vasodilatation. So sympathetic, your systemic vascular resistance decreases. So first is decrease in systemic vascular resistance, right? And because of this decrease in systemic vascular resistance, there is a peripheral pooling of the blood. So decreases venous return and decreases preload, right? So because of these two effects, there is your hypotension. Now, why are these two effects? One is because of the sympathectomy and other is because of the blockage of the release of your catecholamines from adrenal medulla. If you see this image, you see this, the adrenal gland. Adrenal gland is a sympathetic ganglion. We consider it as sympathetic ganglion. Now, preganglionic fibers from T10 to T12 comes and they end in the adrenal gland. They are also blocked. So when adrenal gland is blocked, it does not release the catecholamines. Because of blockage of this adrenal gland and sympathetic nervous system, we are, and other sympathetic fibers which maintains the tone of the blood vessels, we are getting hypotension and bradycardia. So this is because, sorry, firstly hypotension. So sympathetic block and block of adrenal medulla, right? This both causes this hypotension. Now there are certain risk factors in which the risk of hypotension is even more. So what are those risk factors? Certain risk factors. If the age of patient is more than 40 to 50 years, right? If you are giving neuraxial for emergency surgery, right? Emergency surgery, there is a possibility that the volume status of the patient is not optimum. The risk is even more decrease in the preload will happen. More in case of obese patient, the risk of hypotension. Then risk of hypotension more exaggerated with chronic hypertensive patient, right? Because of the sympathectomy which happens. So in chronic hypertensive, right? And it has been seen the risk is more with chronic alcoholic as well. So in chronic alcoholic also, right? The risk is more. Remember this. Then we have bradycardia. Now incidence of bradycardia. Incidence of bradycardia with your neuraxial blockade is 10 to 15%. So incidence is 10 to 15%, and it depends upon the level and the extent of the block. So it depends upon level and extent of block. Now there are two mechanisms of bradycardia which happens during neuraxial. There's two reasons why bradycardia can happen. One is direct, other is indirect. So direct mechanism, direct effect. Now direct effect is the block of cardioaxylator fibers. If you see this from T1 to T4 of all the preganglionic sympathetic fibers which are originating from T1 to T4, they are innervating heart. Okay, T1 to T4. So they are innervating heart. So these are the cardioaxylator fibers. They maintain the heart rate by let's say in synchrony with parasympathetic nervous system. When they are blocked and the parasympathetic nervous system overdrive happens, the heart rate increases because of unopposed the parasympathetic nervous system activity. The heart rate decrease. So direct effect, block of the cardioaxylator sympathetic fibers. So block of cardioaxylator fibers, right? From T1 to T4 is their origin. See, this is less common reason. The more common is indirect effect. The indirect effect, because of hypotension, there is less venous return, less preload, right? And because of this, there is a diffuse, less firing of the myocardial pacemaker cells, right? So indirect effect, decreased preload causes decreased output of the pacemaker cells. So decreased preload Decreased preload causes decreased output of myocardial pacemaker cell. Output of myocardial pacemaker cells. Okay. This is paradoxical basalt-Zarix reflex. Paradoxical basalt-Zarix reflex. Right. Now, because of these two reasons, we get bradycardia. Now, bradycardia is more commonly because of this indirect effect, which is due to this decreased venous return. The pacemaker cells, less firing of the pacemaker cells, the heart rate decreases. This is paradoxical basalt-Zarix reflex. And there are some patients in whom the risk of bradycardia is more. So, what are the patient with high risk of bradycardia? Younger patient. Here, older patient with more risk of hypotension. Here, less than 50 years, more risk of bradycardia. Patient with baseline heart rate less than 60. So, if baseline heart rate less than 60 beats per minute. ASA grade 1 patient, young patient with no comorbidity, high vagal tone. So, they are also at risk. So, ASA 1 patient compared to other patient. Patient on beta adrenergic blocker. So, patient on beta adrenergic blockers. Okay. Then patient in whom the PR interval is prolonged. So, PR interval prolonged. And if the height of the block is above T6, then the risk increases. So, height of block above T6, the risk increases. Okay. So, these are the risk factors. Okay. So, here the bradycardia is happening because of unopposed parasympathetic nervous system. So, how would we manage? By giving a antivagal agent. Here the hypotension is happening because of decreased systemic venous resistance, decreased venous return, decreased preload. How would we manage? We can increase the preload by giving fluids, and we can increase the systemic vascular resistance by giving our patient vasoconstrictor. So, here for management in hypotension, we give fluids to the patient. We can go for the preloading or co-loading along with neuraxial, whatever technique you want to practice, and we can go for vasopressors. Vasopressors like your phenylephrine, ephedrine. So, phenylephrine. Now, phenylephrine is considered one of the best vasopressor for managing the hypotension. But if the heart rate is also low, right, along with hypotension, the heart rate is also low, preferably not use phenylephrine, then go for ephedrine. Ephedrine. Now, phenylephrine we can give in the bolus doses of your 50 to 100 microgram, right? 50 to 100 microgram bolus dose. Ephedrine, we can give the bolus doses of 5 milligrams or even less than 3 to 5 milligram, the incremental bolus doses. So, phenylephrine, ephedrine, vasopressors, okay, on fluids. For bradycardia, how we will do the management? Well, definitely we will give antivagal, vagolytic agents. So, atropine and glycopyrrolate. They can be used. Atropine, what is the dose? The atropine dose is 0.4 to 0.6 milligram, and glycopyrrolate 0.2 to 0.4 milligram, right? So, we will give the bolus doses of atropine and glycopyrrolate as to manage the bradycardia. Okay, so this is the cardiovascular effect. Now, coming the respiratory pulmonary effect. Well, what is the pulmonary effect? Now, studies have shown even in patient with let's say pulmonary disease, they can very easily safely tolerate the neuraxial anesthesia. Now, high neuraxial anesthesia can block the accessory muscles of respiration. Blockage of the sympathetic fibers innervating the bronchus and unopposed parasympathetic fibers can cause bronchospasm theoretically, but these have not much been seen happening in clinically in the patient. So kind of on pulmonary effect, the neuraxial is kind of safe. So remember that though some condition we have to practice some cautions. High neuraxial anesthesia can cause paralysis of accessory muscles, paralysis of accessory muscle of respiration, right? Remember this. If the neuraxial anesthesia is up to mid thoracic level, it has shown to have no implication on the respiratory parameter of the patient, does not affect the lung volume or lung capacity. So mid thoracic level block, no or minimal effect on respiratory mechanics, right? If it is high thoracic block, if it is a high spinal, right, high neuraxial anesthesia. In case of high neuraxial anesthesia, we talked about paralysis of accessory muscle. So forced expiration and coughing of the patient to some extent can be affected. So in patient like COPD patient or patient with secretions, this can cause little problem in them. Okay, so causes paralysis of accessory muscle as discussed. So coughing and active exhalation is affected. So coughing and active exhalation may be compromised. So you need to use it carefully in COPD patient. So you need to give the neuraxial carefully in COPD patient. Avoid high neuraxial anesthesia in COPD patient or patient with secretions, right, which they have to clear with coughing. So avoid neuraxial. Now bronchial tone, though theoretically should be affected, patient should develop bronchospasm, but clinically it is not seen. So bronchial tone preserved, right? Now effect on central nervous system. It has been seen that neuraxial anesthesia causes a level of sedation in the patient. This may be due to decreased input to the reticular activating system, decreased let's say decreased afferent inputs to the reticular activating system, so of the central nervous system, which maintains the wakefulness of the patient. So because of this decreased sensory inputs, this patient have little sedation, and more the duration of the neuraxial anesthesia, higher the duration, more than 60 minutes, 70 minutes, the sedation increases. So when we are using the sedatives, when we give our patient neuraxial anesthesia, you need to be carefully titrate it, and as the duration is increasing, the requirement of sedatives may be decreased. Okay, so sedation is observed with neuraxial anesthesia. Reason, most probable reason, the most probable reason is the decreased afferent input to reticular activating system. So decreased afferent inputs to reticular activating system. So you need to titrate your sedatives properly. So precautions need to be practiced while administering the sedatives. Okay, remember this. Okay, now effect on thermoregulation. As in general anesthesia, under neuraxial anesthesia, the risk of hypothermia is there. And because of this risk of hypothermia, we need to preserve the prevent any heat loss from the patient by doing all the measures like using a forced warm air blanket and covering the patients properly, using warm fluids, etc. Because risk of hypothermia is high with neuraxial anesthesia. So risk of hypothermia, risk of hypothermia with neuraxial anesthesia. The mechanism of heat loss with neuraxial is multiple. There are a lot of reasons why the heat loss happens. One is because of the vasodilatation of the blood vessels, which the neuraxial causes by loss of sympathetic tone, causes the redistribution of the heat from center to periphery. So from core, the redistribution of the heat goes into the periphery, and the core temperature decreases. So number one, sympathetic block redistributes blood flow from core to periphery. Redistributes blood flow from core to periphery. Now heat production decreases due to decrease in the metabolism in the blocked part of the due to neuraxial anesthesia, the blocked part of the organs. So heat production is decreased. Heat production is decreased because of decreased metabolic rate. Right? Now compensatory mechanism below the level of block is lost. So shivering, your etc. is lost. So compensatory mechanism below the level of block is blocked. Below the level of neuraxial anesthesia is blocked. And the central thermoregulation is also impaired because of the decreased input from the blocked area, decreased thermal inputs from the blocked area. So a number of times under neuraxial anesthesia, patient is not even aware of the hypothermia because of the less input to the central thermoregulatory, the hypothalamus. So central thermoregulation is impaired because of blocked input. Got my point? These are the mechanism by which the risk of hypothermia is there. So what should we do? We should prevent the heat loss by taking all the measure. So management is prevention of heat loss. Because we know hypothermia can cause so many impairment in the patient, increase the blood loss during surgery, can cause coagulopathy in the patient, can increase the risk of wound infection in the patient. So we prevent the heat loss and we take all the measures which would prevent this hypothermia to happen in the patient. Okay, so prevention of the heat loss by covering the patient, bear hugger, all should be practiced during neuraxial anesthesia. Okay, then gastrointestinal. See, gastrointestinal, your GI tract is innervated by your sympathetic nervous system, that is from the level and the parasympathetic nervous system is unopposed. So sympathetic fibers to GIT, gastrointestinal system, GIT, is from T6 to L1. Okay, it's from T6 to L1. Okay, parasympathetic is from vagus, which is not blocked. So parasympathetic is unopposed, sympathetic is blocked, and because of this we get a contracted gut, normal peristalsis, and relaxed sphincters. All this gives a good surgical field to the patient, which improves the surgical field of the patient, right? So remember this. Okay, then renal. Now, direct effect of the neuraxial anesthesia on renal is let's say of little significance as long as blood pressure and the cardiac output is maintained. So, the direct effect on the afferent and efferent renal fibers is of no significance. Direct effect of neuraxial anesthesia on renal is of little significance, right? As long as blood pressure and the intravascular volume is maintained. As long as blood pressure and intravascular volume is maintained. Intravascular volume is maintained. In case of hypotension during spinal anesthesia, the renal blood flow is compromised, but once you manage the hypotension, the renal blood flow again becomes normal and the renal function is not affected much. So remember, the effect is not of much significance. Neuraxial anesthesia effect on renal is of not of much significance. Okay, so these are the effects. Now coming on the urinary retention. Neuraxial blocks the afferent and efferent nerve signals to the bladder, both through sympathetic and parasympathetic. Okay, so blocks afferent and efferent nerve signals to bladder, right? Now, sympathetic nervous system fibers from lower lumbar and parasympathetic from sacral, S1, S2 and S3. Both are blocked. So, this leads to the decreased ability to empty the bladder because of the relaxation of detrusor and contraction of sphincter. So, reduced ability to empty bladder, right? So, this causes urinary retention. Apart from this, there is a reduced ability to empty the bladder. We give fluids while in neuraxial to overcome the decrease in the preload. All this contribute to this urinary retention. And this is more seen when the duration of spinal anesthesia is of higher duration. More with the drugs which we use for neuraxial is of longer duration. So risk if urinary retention, risk is more with increased duration of neuraxial. Risk is more if intrathecal opioids like morphine has been used. We have discussed in neuraxial opioids, it can cause urinary retention by having the effect on sacral opioid receptors. So, if intrathecal opioids is used, more in case of old age and more in case of male sex, right? So, more in case of male sex. So, these are the conditions in which the risk of urinary retention is more. Okay, so the more time bladder catheterization is required during neuraxial anesthesia because of the urinary retention. Okay.